Welcome everybody, and good morning, good afternoon, or good evening, wherever you're from. Thanks for joining us today for this CANOE webinar. My name is Jeff Brook, and I'm the Scientific Director for CANOE, the Canadian Urban Environmental Health Research Consortium. And before we begin, I would like to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Before we get started, I'd like to remind you to please turn off cameras and stay on mute during the webinar. If you have questions for our speaker, then please type them in the chat, and we'll have time to answer them at the end as best as we can. Now it's my great pleasure to introduce Hanna Boogaard. Hanna has more than 15 years of experience in air pollution epidemiology. She is a principal consulting scientist at the Health Effects Institute in Boston, Massachusetts. And Hanna is going to speak to us today about a very hot topic, something that the Canadian Physicians for Environment recently released a report on, that is traffic air pollution and its health risks. Health Effects Institute, or HEI, published a seminal report on this back in 2010. That's been widely cited and provided much information important to thinking about the implications of traffic air pollution, something that we continue to be concerned with and experience in Canada and around the world. Now, Health Effects Institute has been working, and I've been part of this panel, to produce an updated report with a tremendous amount of more literature to look at the long-term effects of traffic air pollution. And this is coming out soon, and we're very lucky to have Hanna here today to give us a sneak peek about this report. So I'm going to turn it over to Hanna. Hopefully you'll be able to share, and we look forward to hearing what you have to say. Thank you.
Thank you, Jeff, so much. Let me try to share my screen. Is this working, Jeff? Do you see my slide or not?
Yeah, it looks great.
Yeah. Okay. Super. Thank you so much. Sorry for the glitch here. So thank you for the invitation here, and I'm very happy to talk today about this systematic review. Really, for those unfamiliar with HEI, we are an independent research organization. We provide high quality and impartial science. We get funds both from the US EPA as well as the worldwide motor vehicle industry. And HEI is structured to maintain independence. Although we provide policy relevant science, we do not take policy positions. So let me jump right in. And Jeff mentioned already this 2010 HEI report. I'm sure everybody is familiar by now with this report. It's quite old now, although I guess still relevant, and actually the most cited report from HEI to date. There are detailed chapters there on emissions, on exposure, on toxicology and epidemiology. And at the time, a panel, thought that the evidence was considered sufficient to support a causal relationship between traffic-related air pollution and the exacerbation of asthma in children. The panel also thought there was suggestive and or limited evidence for all the other outcomes that they have looked at the time. Now, of course, there has been a lot of things that have been changed in the meantime. There are many, many, many more papers published. The regulations and vehicle technologies have advanced. And there's much more interest these days in non-tailpipe PM emissions and also in traffic noise. And that is why HEI started a new review, a systematic review this time around in 2018. Now, of course, the big question is, when will this traffic review be published? Well, it's about to be published now. It will be published in about 3 weeks or so. And of course, HEI is planning to disseminate the results widely. We have our HEI annual conference coming up in Washington in about also a few weeks. So please join us there. It's in person as well as it's actually a hybrid, so you can also join remotely. And we are also planning a webinar basically for this official launch of the report that is scheduled for July 13. So please check our website. One other note is that there's already a summary paper, very short summary paper published in Environment International a few weeks ago. So you can also check that out. Now, of course, all this work is a team effort. You know, Jeff was indeed one of our panelists. Very grateful for that. The panel was chaired by Francesco Forestiera and Fred Lerman. There are many great experts in epidemiology on the panel, in exposure assessment and in statistics. We also worked with a great contractor that were doing sort of the searches and the data extraction and all that from the University of Basel. And also really a shout out to colleagues at HEI, specifically Alison Patton, that have done a lot of the work. So let me start with sort of the methods that we used. We have published a review protocol, so it's online for everybody to see. We have used standard methods. We've summarized the epidemiologic results quantitatively where possible using meta-analysis techniques. If there were 3 studies or more, we have done that. We included an evaluation of the risk of bias in individual studies using a risk of bias tool that was also used in the WHO systematic reviews underpinning the air quality guidelines. And at the end of the day, we reached conclusions about the confidence in the evidence. Now, a few important methodological features of the traffic review I would like you to be aware of. Really, this is the largest effort of this type to date. Because the research field is so large, you know, the panel had to come up with some, basically made some painful decisions in terms of scoping. So we evaluated the epidemiologic literature only. And we focused on a selected set of health outcomes chosen a priori. Those included mortality outcomes, cardiovascular, some cardiovascular outcomes, some respiratory morbidity outcomes, and several adverse birth outcomes. And notably missing here are the neurologic effects. We have included them in our special report, so you will see separate chapters on those outcomes, but those were not assessed as systematic as the other outcomes, and that is why they are not listed here. So a key feature is really the selection of only traffic-related air pollution studies. We developed a new exposure framework. Jeff Brook and Gerard Hoek were really instrumental here, and I will talk about it in a second. We focused only on long-term exposure studies. And again, at the end of the day, we assess the confidence in the evidence. We've used 2 complementary methods here with the ratings of very low, low, moderate, or high. And we assess the confidence for the traffic-related air pollution mixture, so not for individual pollutants. So a few words on the exposure framework. You know, as I said, a key feature is the selection of only traffic-related air pollution studies. Now, that's not an easy task. We know that the exposure assessment of traffic-related air pollution is challenging. It's a complex mixture, and traffic-related air pollution is characterized by high spatial and temporal variability. And, you know, still there is no pollutant specific for traffic sources. And the other issue is that traffic-related air pollution, the impacts at different scales. It is not only like the near road environment, right? It's also the neighborhood environment, even the urban environment as well. So the panel developed 3 strategies basically to develop, to select traffic-related air pollution studies in a transparent way. It consists sort of 3 strategies, meaning, you know, in terms of the selection of traffic-related pollutants, in terms of the exposure assessment methods, as well as the spatial resolution. Now, because we assessed so many sort of pollutants as mixtures in of the traffic-related air pollution, we also assessed PM, particulate matter, PM 2.5. Now, for that pollutant, for PM 2.5, even more stringent criteria were applied. For example, the panel excluded studies that were only that were solely based on PM 2.5 monitoring. So that's also, you know, pretty you know, important thing to note. One other note is, as I mentioned before, traffic-related air pollution impacts at different scales, not only the near road environment. So we included also basically the urban scale studies, etc., etc. We excluded sort of the very big studies. For example, the nationwide studies, where really the primary exposure contrast is sort of the between cities contrast, rather than the within city exposure contrast. So we excluded those studies. For example, the CanCheck studies, most of them were excluded, and only if the study, you know, had this adjustment for area, then we were able to include it. So that is just that's sort of to give you a flavor of the level of detail that we really looked at each and individual study. So a few words on the confidence assessments to get to this overall confidence rating for traffic-related air pollution. We used 2 approaches, as I said before. First, we used OHAT. I will come to OHAT in a second, but basically there were separate assessments for each exposure outcome pair by study design. Then those were sort of summarized for each exposure outcome pair, then for each health outcome, and then in addition, a narrative assessment was conducted for traffic-related air pollution and the outcome separately. And as I mentioned before, not for every exposure and outcome pair. And you know, the panel considered both approaches equally valuable. So on OHAT, how it works is that there is this initial confidence rating based on study design features. You'll see here those features in the gray box here, and then there is sort of up and downgrading based on certain factors. For example, there is a downgrading factor for risk of bias, and there's an upgrading factor for dose response or consistency. And in original grade guidance, all observational studies, they start basically at a low confidence level. Now, OHAT decided that prospective cohort studies can also start at a moderate level, whereas in the traffic review, basically we decided to start with a moderate confidence for all cohort studies as well as case control studies. Why? Because 3 of the 4 design features that are in this gray box here were often met. Basically, only the controlled exposure is not met, because that is only met in sort of those randomized controlled trials. They only meet that requirement. Now, the panel deemed it necessary to accompany this grade type approach also with a broader, I call it a narrative assessment, because, you know, the panel was convinced that the grade methods remain imperfect and the application was challenging, partly due to the mechanistic up and down grading related to certain factors. Other reasons to develop a complementary narrative assessment was also because the grade type assessments, they focus more on the quality of the body of evidence rather than the presence of an association. And in addition, those assessments are heavily geared towards studies entering a meta-analysis. So now both assessments consider many of the same aspects relevant in evidence syntheses, of course, but there are some differences, sometimes subtle differences. For example, the direction and magnitude of the association, as well as the consistency of the findings, they played a major role in the narrative assessment. For example, associations that were replicated in several studies across different populations, across several pollutants, or that used different epidemiologic approaches, they were more likely to represent a true associations compared to sort of isolated single observations from individual studies. And there were other subtle differences. Next, I'm going to present you some results. Of course, it's a snapshot. I'm sure you can appreciate that the report is large, it's huge, with so many studies, with so many outcomes, with so many pollutants. But let me share a few slides with you on the results. So we searched the literature from January 1980 all the way up to July 2019. So January 1980, that was also the starting date of the earlier HEI traffic review. At the end of the day, we included 353 studies in the systematic review. About half of them entered a meta-analysis, and in addition, we included 69 studies for the neurologic outcomes, and sort of that those are sort of the separate literature reviews I mentioned before. Most of the studies that we've found reported on respiratory outcomes in children or on birth outcomes, and fewer studies were available for cardiometabolic outcomes, for respiratory outcomes in adults, and in mortality. In terms of when the studies were published, most of them were published after 2008. So relatively recent. October 2008 was the cutoff date of the earlier HEI traffic review. So the majority of the studies were done in Europe and North America. Studies in Asia, predominantly China, emerged more recently. And clearly, there are more traffic-related and health studies needed in low and middle income countries. Now, in this figure, you'll see the number of studies by outcome and pollutants. NO2 was the traffic-related exposure indicator that was most widely used, followed by elemental carbon / black carbon and PM2.5. Also, about half of the studies, they reported on indirect traffic measures, such as distance to roadways or traffic density. And although they are informative, the panel could not combine them for use in meta-analysis because of all the varying definitions. Another thing to note here is that there were very few studies identified. I'm talking about long-term studies, obviously. There were very few studies identified for some pollutants, such as ultrafine particles and PM components, specifically non-tailpipe PM indicators. And such studies were identified as a future research need. And that's exactly why HEI is doing additional research on in this area. Also of note is that many of the studies included more than one exposure metric. And of course, if they met our exposure framework, we extracted all that information. Now, moving on to some of the meta-analyses conducted. I have 4 slides on those. So this is a forest plot for NO2 and all-cause mortality. We identified 11 studies in total. You'll see here the individual estimates and the summary estimate in bold. Almost all the individual studies, they reported positive associations, and the summary estimate is also positive and statistically significant. Now, looking at the heterogeneity test, for example, the I-square, you'll see a high degree of heterogeneity, 83%. The panel decided not to downgrade for inconsistency here, because almost all the individual studies, they reported positive associations, and really the heterogeneity is mainly stemming from the variability in the magnitude of the positive association, not in the direction of the association. Now, this is a summary plot basically with all the main meta-analyses conducted for the outcome all-cause mortality. So not only NO2 that I showed you before, but also for all the other pollutants that we had enough studies for to conduct a meta-analysis. Now, the summary estimates basically documented positive associations between all the traffic pollutants and all-cause mortality, with point estimates ranging from 1.01 to 1.06. And the summary estimates for NO2, for elemental carbon, and for PM2.5, basically the pollutants with most of the studies, more than 10, they were statistically significant. 2 important notes here. Effect estimates cannot be directly compared across the different traffic-related pollutants, because the selected increments do not necessarily represent the same exposure contrast. Another important note here is that really the individual pollutants, they are considered as indicators of the traffic-related air pollution mixture. They are not, those estimates are not independent from each other. Moving on to some of the other meta-analyses. So this is a plot with the same information as the earlier plot, but also showing the meta-analyses of other causes of death, including circulatory mortality, and only for the pollutants that were most widely used, NO2, elemental carbon, and PM2.5. Bottom line, similar positive associations were seen for other causes of death, in particular for circulatory mortality and ischemic heart disease mortality. Also of note is that the number of studies were typically lower for lung cancer, and the number of studies were typically lower for respiratory mortality. And the resulting estimates were less precise. So this is my last slide in terms of the meta-analyses. This is a similar plot as before, but now for some morbidity outcomes, birth outcomes, respiratory outcomes, and cardiometabolic outcomes. Now, I know it's a lot to digest. Let me say a few things. So the story is more complicated for some of the morbidity outcomes than for mortality. Typically, fewer studies were available, and especially there were few studies identified for some of the cardiometabolic outcomes. For cardiometabolic outcomes, perhaps most convincing evidence was found for diabetes. And really, the panel identified several issues with this body of evidence, with specifically for the cardiometabolic outcomes that might have influenced its informativeness. Most importantly, the panel reported that outcome misclassification may be a real issue here. Also of note was that there were no associations reported for NO2 and ischemic heart disease events, and also no associations for NO2 and stroke events. A few words on birth outcomes. So most evidence was found for a positive association for term low birth weight and for a small for gestational age. Notably, positive associations were reported for PM2.5 as well as PM10. PM10 is not in this picture, but associations for other meta-analyzed traffic-related pollutants, including NO2 and elemental carbon, with all the birth outcomes were essentially null. Most of the studies used registry data. They lack potentially important covariate information on lifestyle factors, such as maternal smoking, as well as BMI. And as a result, many of the birth outcome studies were rated as high risk of bias studies for a potential confounding, and it reduces the confidence in the body of evidence, particularly for preterm birth. Now, regarding respiratory outcomes, strongest evidence was found for asthma onset in both children as well as in adults, and in acute respiratory infections in children. Basically, studies examining exposure to NO2 made the greatest contribution here to this evaluation. And just to note that the panel also assessed prevalence of asthma ever and also prevalence of active asthma in children. And they found moderate evidence for association for those outcomes. And also a note that for most of the other respiratory outcomes investigated, including incidence of COPD in adults, many wheeze outcomes, as well as the exacerbation of asthma, basically the confidence was very low or low in an association with traffic-related air pollution. And it was hampered by the small number of studies at the end of the day. So what you see here are the confidence ratings in the evidence for an association with long-term exposure to traffic-related air pollution. So you'll see here the two approaches that I mentioned side by side. So basically, this is indeed the last step in the systematic review, looking at the full body of evidence, focusing on all pollutants as well as the indirect traffic measures collectively for a given outcome. So not only NO2, not only elemental carbon, but really collectively. And the findings provided a high level of confidence in an association between traffic-related air pollution and all-cause mortality and circulatory mortality, as well as in ischemic heart disease mortality. And the confidence in the evidence for an association was moderate to high between traffic-related air pollution and asthma onset in both children and adults, as well as in acute lower respiratory infections in children, as well as in lung cancer mortality. The panel's confidence in the evidence was considered moderate, low, or very low for all the other selected outcomes. Another note here is that for the most part, these complementary assessments, they reached the same confidence conclusions in the traffic review, though, you know, there were some exceptions, and particularly notably were the stroke mortality and the stroke morbidity assessment, where basically one assessment assessed a moderate confidence and the other one a low, as well as the other way around. So the last picture, this last picture basically contains much of the same information as the previous picture, but what is shown now here are sort of the overall confidence assessment, the overall confidence ratings, basically combining the narrative assessment and the modified OHAD assessment. So thus, if both were high, rated high, then of course the overall assessment is also high. And you'll see indeed that for all-cause mortality, for circulatory mortality and ischemic heart disease mortality, indeed this was rated high. Note that in this picture, the outcomes that were rated as low or very low to low, etc., are not in this picture. Now, some key observations of this review. Now, obviously, this review has many more studies than the 2010 report, though a direct comparison is difficult because of the differences in scope and methods, etc. I mentioned that only half of the total numbers of identified studies entered a meta-analysis. So the most common reason for a lower confidence judgment was the downgrading factor imprecision, and that was most often applied in the cardiometabolic outcomes. So it really calls also for basically additional studies on those outcomes. And the most common reason for a higher confidence judgment was evidence for a monotonic exposure response relationship. And just to note that most of the studies were rated as low to moderate risk of bias, basically for all but the confounder domain. Now for the confounder domain, about 1/3 of the meta-analyzed studies were rated as high risk of bias. Now, that doesn't mean that in all those cases, we applied downgrades in terms of risk of bias. Of course, only a body of evidence was downgraded when the effect estimates from the studies at low or moderate versus high risk of bias, if they vary considerably, and also if the body of the evidence with low or moderate studies, risk of bias studies is limited, basically. So if there are only few studies in the low or moderate category, and you have those many studies in the high risk of bias category, of course you have to think about that a lot. If there is no difference in effect estimates between high risk of bias studies versus lower risk of bias, there's no need to downgrade. Also, if the high risk of bias studies, if they vary considerably in terms of the effect estimates, but if there are sufficient studies in the low or moderate categories, then you can just omit the high risk of bias studies from the confidence rating entirely. So then there's also no need to downgrade. So anyways, those are all considerations, and they are all also basically it's standard guidance also from GRADE how to deal with that. Now, the conclusions from the two confidence assessments, they broadly agree. Of course, this is reassuring, but also, those evaluations were done by the same people at the end of the day. So, those comparisons are inherently limited. And although the evidence is compelling for some of the outcomes, the panel identified a number of future research opportunities. And I list here several of them. There will be many more in the report. So we have actually a huge table in the report on future research needs. I have listed a few here, and some of them I've already addressed. So the review focused on an evaluation of the epidemiologic evidence only. The special report, they will include sort of a high-level, succinct review on the mechanistic evidence, but admittedly, the considerations of other lines of evidence, including mechanistic evidence, is limited. And that is exactly why the panel refrained from assessing causal determinations. Basically, we still talk about associations. We don't talk about causal associations or causal relationship because of that. Although I must say, for a similar confidence assessment was done for the epidemiologic reviews underpinning the air quality guidelines of the WHO. So they developed air quality guidelines based on that. So maybe we are a little too strict here in avoiding the word causality. But anyways, a more thorough evaluation of the mechanistic evidence would have aided the panel's interpretation. That's for sure. More broadly, the review was limited to traffic-related air pollution, though some consideration was given to traffic noise. Clearly, there is a need for more studies to evaluate the role of spatially correlated factors, socioeconomic status, traffic noise, and factors related to the built environment, such as presence of green space. And there's also a clear need to evaluate the fuller range of potential impacts of transportations and new mobility on public health. This includes the opportunity for physical activity and active transport to mitigate the adverse health effects of traffic-related air pollution. And you know, as shown in this very nice picture, there are many intertwined pathways between transportation and health. There are 14 now, I guess 14 and still counting. But anyways, think about urban heat islands, think about climate change, think about social exclusion, of course, traffic noise. So a word on new mobility. It is uncertain, of course, whether the results of the traffic review apply to a setting where the vehicle fleet is, you know, totally automated, totally electric, totally shared. Of course, it also depends on where the energy is coming from. But regardless, certain challenges of traffic-related air pollution remain to be resolved in the foreseeable future. Think about traffic congestion, think about high-emitting vehicles, etc. Lastly, there is a need to improve methods in systematic reviews and evidence syntheses of observational studies in environmental health. And I have one slide on this because we just submitted a journal article on sort of the lessons learned here. And I have touched on several of them already. Really, the panel thought to maximize what can be learned from observational studies, that sort of a narrative approach is needed to complement the mechanistic up and down grading of certain factors when evaluating the quality of a body of evidence. And observational studies, they can offer high confidence evidence in environmental health, where randomized controls trials, they are generally not feasible. And it's good to realize that, you know, the great framework was designed for guideline development for beneficial therapeutical interventions in clinical medicine. GREAT was not designed to assess potential harms from environmental exposures. And the fact that there are no RCTs available really cannot be a reason to start at lower confidence. And really, for future assessments, the panel recommends that observational studies, especially cohorts and case control studies, should start with a high confidence rating. And of course, this initial confidence rating for a body of evidence from this type of studies can then be downgraded if substantial biases are likely that would affect the effect estimate significantly. Now, this is already a point I made earlier, that really all relevant studies should be included. We know that studies that end up in a meta-analysis, it's only a subset, and it's very important to look sort of at all the studies collectively. Consistency of associations across study designs, populations, and exposure assessment methods really provided additional confidence in the results. The panel thought that was a very important criteria. And you know, the original grade framework does not even have an upgrading factor for a consistency. Basically, you can only downgrade for inconsistency. Now, OHAD realized that, and they added an upgrading factor for consistency, which is great. And actually, all other frameworks for environmental health evidence synthesis, they have this consistency upgrading factors. In IARC, they have that. Also in the weight of evidence approach from the EPA, it's a very important factor. Lastly, the panel agreed that a critical step in the systematic review process is assessing the risk of bias of individual studies. Now, there's no consensus about the best approach for assessing risk of bias in observational studies. And for future assessments, really, the panel calls for identifying and quantifying possible key biases, their most likely direction, and their potential impacts on the results, instead of using a risk of bias tool. Basically, they recommended an approach that was actually published by David Savage a few years ago. You should check it out. It's a very nice idea, but the panel thought such an approach would be much more informative than a risk of bias tool. Really, the issue is that the risk of bias indicates the potential for the results of an individual study to be biased. It does not inform on actual bias in a particular study. The other issue is that a score of moderate or high risk of bias, they do not inform you on sort of the size of the potential bias. It can be down or up, or nothing happens at all. So there are all those issues with the risk of bias tools that we currently have. So stop here. So here are the overall conclusions from the traffic review. No surprises here. What is listed here, I'm not going to read this aloud, but really, in light of the large number of people exposed, both in the near road environment as well as outside the near road environment, the findings indicate that traffic-related air pollution remain an important public health concern, and that it deserves greater attention from the public and from policy makers. Now, that is what I wanted to share today, and I'm going to stop sharing now, and happy to answer any questions. Back to you, Jeff.
Thanks very much, Hannah. It's so much to cover in a short amount of time, and you did it really great justice. I appreciate you touching upon the challenges of assessing evidence in environmental epidemiology. It's something that continues to evolve. We do have a number of questions in there, and I can go through several of them. I know at the beginning you made it clear that the goal here was to look at the effects of long-term exposure, and that led to difficult decisions about what outcomes to include. What do you recall about cancer incidents? I know cancer mortality was in there, but cancer incidents, was it just a lack of number of studies to include?
Yeah, so we, as I mentioned, we had to make some painful decisions here. We had to, come up with a set of outcomes to look at. At the end of the day, we decided to only include lung cancer and mortality. We considered lung cancer incidence as well, but, because of, unfortunately, it's still, I'm not saying that it's the same, but, because we had already lung cancer mortality, we decided to not look into a lung cancer incidence for this review. We considered also other outcomes. I believe we had, at one point, we had indeed some of the childhood cancers. You know, because there are some studies on there, especially with benzene and some of those childhood cancers. But really, we had to make a decision, and it's never perfect. That's for sure.
Mm-hmm. Clarification in terms of the exclusion criteria for the cohort studies. I think, you know, a key one was, of course, needing to be looking at within city interurban. Are there other key exclusion criteria that you can refresh us on in cohort studies?
I think, you know, in terms of the cohort studies, of course, we had some strict criteria in terms of the exposure assessment. And of course, because it had to be long-term exposure. So we had this criteria that at least, and we said sort of long-term, meaning several months to years. So that was also sort of a criteria. And again, you know, this exposure framework was definitely sort of the most important, I guess, exclusion criteria here, that we really looked at all the studies carefully, and we really checked whether the exposure assessment was sufficient to basically to capture traffic-related air pollution.
Mm-hmm, mm-hmm, thank you. The number of questions about climate, and it sort of comes up in, you know, the forward-looking issues around the new mobility and how that might be motivated by climate, but you know, also concerns that we know that there are climate factors that may be impacting us. You know, weather and climate is common to look at in the short-term studies. Any thoughts on whether or not there's some interaction with climate, say heat or other factors in the long-term studies that would be relevant? You talked about, you know, noise and cofactors like that, but you know, what's your thoughts on climate? Would it be something that might influence susceptibility of populations in some way?
Yeah, well, I mean, obviously, of course, you know, first thing you think of is indeed, you know, the short term, indeed the short term studies where they looked at temperature, etc. But I mean, I definitely there is something there also for the for the long-term effects. That's exactly why we also list climate and heat-related issues also sort of in the future recommendations, because there are not many studies indeed that have looked at it. But you know, especially with the changing climates, we think it can be an important factor.
Thanks. And, you know, now, and talking about the short-term studies, do you have it down in the back of your mind or in the front of your mind, some of the key things from the previous assessment about short-term studies? You know, we weren't able to assess them in this one, but that was considered in the 2010 assessment. You know, what were some of the short-term effects that at that time were felt to be having sufficient or strong evidence of effects in terms of, you know, short-term acute effects? Do you recall?
Yeah, thank you, Jeff. You know, first of all, in our new traffic review, it's not that we completely ignore the short-term effects. We will have you will see in the special report, we will have a separate chapter on the short-term effects. Now, this was not systematic; it's really sort of high-level, succinct, but at least there's something. In the 2010 report, indeed, we included some of that. But I cannot recall whether there was sort of stronger evidence for sort of the short term versus the long term, etc. Sorry, I cannot recall that.
Yeah, I'm not. I know we talked. Well, there are a lot of studies on rises and falls and asthma exacerbations in the short term, but it becomes harder and harder to really lay the blame in the time series studies on traffic air pollution by itself. You don't have.
Yeah, Jeff. One other thing is, by the way, because indeed in the 2010 review, remember that, you know, the panel then sort of assessed sort of asthma exacerbation in children, and they said that there was a causal relationship between traffic-related air pollution. Now, that doesn't we think about asthma exacerbation as a sort of a short-term effect, but if you look at the definitions that were used, etc., you know, as you know, it's very difficult, right, to assess asthma. Is this asthma exacerbation? Is this sort of asthma ever or active asthma, right? So there's a lot going on often in those studies, and we also looked at asthma exacerbation, but only in patients, basically, and indeed only long-term studies. Whereas, of course, most of the asthma exacerbation studies are on short-term exposure studies.
Right, thanks. A question about exposure assessment, and the central assumption often here is that home address is sufficient for exposure. Many questions from Dr. Teresa Toe. And we know that adults certainly are mobile. Any sense as to how that might play into the evidence here, or ability to improve work along these lines?
Yeah, I mean, we in the exposure framework that we developed, we have been strict in terms of what the sort of the address level should be, what should be the aggregation, what should be the exposure assessment methods, what's the spatial scale, etc. Of course, it was not that we only said, okay, only studies that are at the individual level, postal codes are included, and we ignore all the other studies. That is not what we did. But there were definitely some requirements in terms of the spatial scale of the exposure and the linkages to the health data.
Now, I think it's sort of the common question of whether or not just using residential address is enough. Yes, you can resolve it, as you described. And we know that people spend time elsewhere. We know that there is research that tries to look at, say, home and work or home and school, to time-weighted exposure. Do you have any insight on that issue about time spent away from home and how that could have influenced results?
Yeah, we have obviously for this exposure framework, we allowed, of course, all those other studies as well, because indeed, it's not that people are like home all the time. So, and also we included the studies in children at the school level, for example. There are some of those. So those were all included. In terms of of course, because we only looked at sort of long-term exposure studies, and at the end of the day, really most of them are still on residential address, right? But although there are some studies coming in now with sort of using novel sensors, time activity patterns, etc. But there's not many of that, especially not for long-term exposure at the end of the day. And in the future research needs, of course, we have also a section on the improvements in traffic-related air pollution studies, indeed using novel sensors, using novel technologies, and I think many people are working on those issues.
Now, you're well versed in the European and the WHO realm, and we know that last fall the WHO decreased the NO2 standard dramatically, the long-term exposure for NO2 dramatically. Here we used NO2 a lot. You're very clear that this is an indicator of traffic air pollution. Do you have any insight on NO2 as a pollutant by itself as a risk versus as an indicator of air pollution?
Yeah, that's the $1,000,000 question, Jeff. That's the question we try to address for years, not successfully. No, I mean, for the traffic review.
What's sway WHO and maybe some of the European perspectives?
Oh, we are leaning more and more towards that there are direct effects of NO2 in itself. Yes, absolutely. You know, for the traffic review, you know, as I've been very clear, you know, we consider them as indicators of the traffic-related air pollution mixture. It's so we can't say like, oh, it's NO2 or it's whatever elemental carbon, but you know, looking at the broader literature, looking at more recent evidence, you know, it's getting more and more clear that indeed NO2 is an important pollutant that have a direct effect on health.
Great. That's good to be able to just reiterate that, because it is a really critical question, and it can do both, right? It does do both, I think. Really important question about policy. So, you know, it seems clear that, you know, TRAP is not good. Evidence continues to grow, but this is a very challenging thing to mitigate. We see that vehicles have been getting cleaner, and that's a separate question about TRAP studies of old traffic air pollution versus current traffic air pollution. But just in terms of policy, and the priorities that were identified, is there really additional data that you think are really critical to get for policymakers to be more able to act?
Yeah, that Jeff, that's a difficult question for me to answer, because you know we stayed away from policy implications altogether, right? You know, in the you'll see also in the special report that we don't talk about sort of, you know, the mitigation measures and like all the possible options you can think of, including, you know, low emission zones, etc., etc. So that is really not the focus of this review.
Yeah. Yes, that's a challenging task in its own right. And I see that we're at 1 minute to the hour. Lots of things we could continue to discuss here, but time is short, and really look forward to seeing this out in the 22nd of this month. Of course, some reviews again at the HEI conference later this month also. And it's, I think, going to be great, very helpful for researchers and policymakers alike to see this information. So really appreciate getting this early peek at what's there. It's been, I think, presented very clearly. We had a great audience today, so
absolutely.
And your European time to join us. Hopefully we haven't interrupted your evening too much, but again,
no, thank you so much, Jeff. And
yeah, wonderful. And I thank the audience for joining, and hopefully that report will have long-term lasting impact, as we hope it will. So take care, everybody. Thanks again. Bye-bye.